Alright, so today we're going to talk about survival in 76 cats with epilepsy of unknown cause, a retrospective study. This is out of 2017 in the journal Veterinary Record, and it's coming to us from Switzerland. It's open source, so let's go ahead and get started.
Survival in 76 cats with epilepsy of unknown cause, a retrospective study. Survival of cats with epilepsy of unknown cause has not been reported. Seizure epidemiology and its relationship to treatment outcome and survival was studied in a population of 76 cats. A questionnaire for seizure epidemiology was developed based on experimental data. Seizure epidemiology was characterized by owner interviews at least 1 year after discharge. Seizures were classified as primary generalized and focal without, and with secondary generalization. Median age at seizure onset was 4 years. 1/3 of cats with EUC presented with primary generalized seizures, and 78% of those with initially focal seizures progressed to secondary generalized seizures. Clinical signs of generalized seizures included sudden onset of loss of consciousness and tonic-clonic seizures, while cats with focal seizures had unilateral signs. Anti-epileptic drug therapy was initiated in 62 cats. Complete remission rate was 42%, and the median survival time was 3.2 years with or without AED, and 91% were still alive at the time of interview. Neither epidemiology nor seizure type predicted survival. Response to treatment and outcome in cats with EUC. A seizure-free status of more than 12 months was observed in 79% of cats without AED. Epilepsy in dogs and people is associated with an increased risk of death, and the disorder may be associated with reduced survival rates. In contrast, no such studies have been published on cats with epilepsy. The original classification scheme for epilepsy in human beings from the International League Against Epilepsy in 1989 divided the seizure etiologies into idiopathic, symptomatic and cryptogenic epilepsies. Idiopathic epilepsy was defined as chronic recurring seizures without any underlying structural, brain lesions and other neurological signs and is presumed to be genetic in origin. Symptomatic epilepsy was due to identifiable cerebral lesions. The term cryptogenic is used when a specific cause cannot be identified, but is suspected due to persistent neurological signs. More recently, the term epilepsy of unknown cause has been adopted to classify seizure disorders where no underlying cause can be identified, based on a recent classification system by the International Veterinary Epilepsy Task Force Consensus Report in 2015. EUC replaces former terms such as idiopathic epilepsy and primary epilepsy, and embraces categories such as cryptogenic epilepsy and presumed idiopathic epilepsy. Reported prevalence of feline EUC ranges between 22 and 54%. The main diagnostic criteria in cats with EUC include absence of pathological findings by diagnostic imaging and cerebrospinal fluid analysis, and/or a history of seizures with no abnormalities detected on neurological examination during interictal periods. The median age at onset of seizures in EUC is generally less than 7 years, but the range varies considerably between 0.4 and 14.4 years, and no breed or sex predilections have been identified. In one study, 30% of cats with EUC were poorly controlled, but in contrast seizure-free intervals of several months and years have been reported. EUC includes a variety of yet-to-be-determined etiologies, which may respond differently to anti-epileptic drug therapy, and they may also have different outcomes. There is a need to introduce new tools that improve characterization and prognosis of cats with EUC. Recent technological advances such as ictal video monitoring, interictal non-invasive or invasive electroencephalography, magnetoencephalography, structural and functional magnet resonance imaging or nuclear imaging can be helpful in the better characterization of seizure disorders of unknown etiology, but are hardly available for animals to date. In contrast to these high-end technologies, informant-described seizure onset characterization and ictal behavior are still required to define seizure type and assess response to anti-epileptic treatment. This information is available from most cat owners and may represent the only source of information along with a clinical neurological examination because of limited ability to pursue diagnostic testing in clinical practice and infrequent seizure episodes restricting direct observation during a clinic visit. The value of analyzing and describing seizure epidemiology has previously been demonstrated in cats with experimentally induced epilepsy. Following the induction of seizures by various systemically and intracerebrally applied pharmacological agents, detailed observations and descriptions of seizure phenotypes have been made in cats. With each experimental setting, uniform and specific patterns were described suggesting that certain triggers produced characteristic seizure phenotypes. The association of seizure type based on semiological features and outcome as well as survival has to date not yet been examined in a larger population of cats categorized as EUC. The purpose of this retrospective study was to examine survival and treatment outcome in cats with EUC in relation to semiology and seizure type, materials and methods. Medical records of cats with a primary complaint of seizures, presented between 1997 and 2012 to the section of neurology, Vetsus faculty of the University of Zurich, Switzerland, were reviewed. Information on signalment, age at onset of seizures and number of seizures before presentation was retrieved. At the time of admission, all cats had to have experienced more than 3 seizure episodes that were clearly separated from each other by at least 1 day. Cats with reactive seizures, which occur as a natural response of the normal brain to a transient disturbance in function, were excluded. Furthermore, results of clinical and neurological examinations, hematology and serum chemistry tests and infectious disease screening were evaluated. If available, results of CSF analysis, CT and/or MRI were used for analysis. Owners of cats with EUC were contacted by phone at least 1 year and maximally 15 years after their cat's first presentation for seizures at the clinic. If an owner of a cat could not be reached, the cat was excluded from further study. All owners were interviewed by one of the authors, and responses were also reviewed by one neurophysiologist and boarded veterinary neurologists. Seizure etiologies were determined based on the International Veterinary Epilepsy Task Force Consensus Report. To be included in the study, cats were required to have a normal interictal neurological examination, normal hematology and serum chemistry, and a normal CSF analysis. Normal cross-sectional imaging of the brain was an optional inclusion criterion. Seizure type was classified based on seizure into primary generalized tonic-clonic seizures with focal onset and focal seizures with secondary generalization. Primary generalized seizures were characterized by acute onset of lateral recumbency and tonic-clonic limb movements accompanied by autonomic signs and loss of responsiveness. Focal seizures were defined as paroxysmal occurrences of abnormal movements of one part of the body, such as contractions of one limb or facial muscle group, with or without impaired consciousness or autonomic signs, such as salivation and involuntary urination and defecation. Interviews regarding semenology were performed using a detailed questionnaire specifically designed for the purpose of this study. Specific questions regarding semenology were created based on a review of the literature for clinical signs observed in experimental epilepsy studies reported in cats. Data from 9 experimental studies describing the semenology and the localization of the affected brain regions were selected. The questionnaire contained specific and open-ended questions about semenology and was used by the first author to collect information during phone interviews. Outcome questions included recording of survival from time of discharge, initial and subsequent clinical features of seizures, owner perceived general health status of the cat at time of follow-up, frequency of seizures, and if medical treatment was required to control seizures. Partial remission was defined as reduction of seizure frequency by greater than 50% with AED therapy at the time of follow-up. Complete remission was defined by a seizure-free period of at least 1 year with or without AED therapy. Epilepsy-related cause of death was defined as euthanasia motivated by circumstances directly associated with seizures. If the cat died or was euthanized for reasons unrelated to seizures, death was registered as due to other causes. Cats that were lost to follow-up were censored at the time that they were last known to be alive. Statistics. All the statistical analysis was undertaken in R. Survival analysis using a Cox proportional hazard regression models was undertaken using the Cox function in the survival package. A parametric survival curve was also fitted to the data using the servert command from the same package as a comparison. We also undertook a relative survival analysis using a life table for Japanese cats. This was the only life table available for cats. For this analysis we used the RealSurv package. Kaplan-Meier curves were also calculated to illustrate the survival curves of this group of cats suffering from epilepsy and any differences in survival of cats with and without remission. Fisher test was used to analyze differences in proportions of cats receiving treatment and undergoing remission. Results. Study population. During a 15-year period between 1997 and 2012, a total of 226 cats were presented with seizures to the Vetsus Clinic Zurich. Adequate medical records were available from 197 cats for further analysis. However, 35 cats were euthanized or died due to presence of intracranial pathology or request from the owners during initial hospitalization, and 12 cats were found to have reactive seizures due to metabolic, toxic etiologies and were therefore excluded. Another 70 cats were excluded because owners could not be reached. For 80 cats, that is, 36% of all cats with seizures, the owners were available for follow-up information after hospitalization. Based on additional medical record and follow-up information, 4 cats were found to have structural epilepsy and were therefore excluded. Thus, the remaining 76 cats were considered to have EUC and were included in this retrospective study. While domestic short hair were by far most commonly represented among the 76 cats with EUC, there were 9 purebred cats, including 3 Maine Coon and 2 Persian cats and 1 Siamese, Norwegian Forest, Bengal and Bombay cat. In addition, there were 4 cats of unknown breed. This breed distribution reflected the typical feline patient population at the author's institution. Sex distribution was equal with 3 entire and 35 neutered males and 6 intact and 32 spayed females. The median age at seizure onset was 4 years. Seizure type classification based on semenology. Of the 70 cats with EUC and available semenology information, 23 cats had primary generalized seizures. Clinical signs included sudden onset of loss of consciousness, primary generalized tonic-clonic seizures, salivation, urination and or defecation. Owners were not aware of any preictal signs such as changes in behavior. Owners of 4 animals reported that seizures occurred first during sleep. Focal seizures were observed in 47 cats. Preictal abnormal behavior signs were noted in 9 cats minutes 2 hours before ictal signs occurred. The cats appeared to be awake, but confused, and not properly reacting to external stimuli and to the owner. Clinical signs of focal seizure activity included rapid conscious running, clonic movements of one body part such as tail or one limb, twitching of unilateral facial muscles, and circling in one direction. Progression from focal to secondary generalized seizures was observed in 78% of cats with focal seizure onset. There was no statistical difference in the median age between cats with focal seizures and cats with primary generalized seizures at onset of seizures. Outcome and survival. Overall, the median time of follow-up of surviving cats with EUC was 3.2 years. 24 cats died during the study period. The median survival time was 1 year. Death appeared epilepsy-related in 16 cats, and 8 patients died due to other causes. Age at time of seizure onset and remission were significant independent predictor of survival. The hazard ratio for age at onset was 1.12. This means that there was a 12% increase in the risk of death per time period for each increase of 1 year from the onset of seizures. For the 76 cats, the median survival time was 4.9 years. The hazard ratio of remission was 10.4. Thus, the risk of death was 10 times higher in cats without remission compared with those that showed remission per unit time period. Treatment with AED therapy was started in 62 cats during and or after hospitalization. Reasons for not starting or discontinuing treatment were not specifically instigated, but generally included an ability to pill the cat, recommendation of referring veterinarian or spontaneous decision of the owner. Phenobarbital was given to all treated cats either alone or in combination with diazepam or levetiracetam. Median survival time of treated cats was 2.3 years. and 65% were still alive at the time of follow-up. Treatment appeared effective in 44 cats. Complete remission with AED therapy was achieved in 21 cats, with a median time of follow-up of 4.3 years. These cats were still alive at the time of follow-up except for one cat, who died after 5 years due to an epilepsy unrelated cause. Partial remission was observed in 23 cats with AED therapy, and 15 were still alive at the time of follow-up. 8 cats died after a median survival time of 1.5 years. Death appeared epilepsy-related in 4 cats, and another 4 died due to other causes. The remaining 18 cats showed no remission with AED therapy, and 13 have died at the time of follow-up with a median survival time of only 0.3 years. In 12 of 13 cats, death or euthanasia was epilepsy-related. In 14 cats without AED therapy, the median time of follow-up was 2.6 years. Complete remission without AED therapy occurred in 11 of 14 cats, with a median time of follow-up of 3.2 years. At follow-up, 12 of 14 cats with EUC were alive, while 2 cats died for other reasons. A total of 32 of 76 cats became seizure-free with or without AED, including 14 animals with primary generalized tonic-clonic seizures, 5 with isolated focal seizures and 10 with focal seizures and secondary generalization. In 3 of 32 cats with complete remission, death was not epilepsy-related. The 29 cats with complete remission still alive had a median survival time of 3.2 years. There was a significant difference in the hazard ratio of cats achieving remission. Thus, cats that went into remission had a longer survival time. This was true both with the Cox survival model and the relative survival model using normal Japanese cats as the control group. Cats that were treated were more likely to be in the group that did not undergo remission, but treatment had no independent effect on survival times. No significant differences between seizure type and outcome were observed, and thus seizure type did not predict outcome in cats with EUC. Discussion. In this study, 68% of cats with EUC survived for a mean follow-up time period of 3.2 years, and seizures were successfully controlled in 71% of the cats. Similarly, previous studies reported high survival rates and good outcomes in cats with EUC. In contrast, in 29% of the cats in the present study, seizure control was not successful, and in 21% death was related to seizures. Thus, identification of prognostic predictors is important for the motivation of clients to pursue treatment of cats diagnosed with EUC. One objective of this retrospective study was therefore to look for easily accessible information from clinical examination and owner interviews that allow more valid statements on outcome in affected cats. Neither semiology nor seizure type was associated with outcome in terms of survival in the present survey. Moreover, seizure type based on semiological classification was not predictive of seizure etiology, which is similar to what has been previously reported. Despite this, careful recording of semiology and seizure type remains important when evaluating seizure in cats. Specific seizure disorders in cats have been reported, including complex partial seizures with orofacial involvement in cats with limbic encephalitis and myoclonic seizures before generalized tonic-clonic seizures in cats with audiogenic reflex seizures. A very recent study found that ictal salivation is likely to be associated with EUC. Salivation was also one of the most common signs in cats with EUC. In the present investigation, recording of the initial signs of seizure events is required for determination of the so-called symptomatogenic zone, defined as the area of cortex which, when activated by an epileptiform discharge, produces the ictal signs. These indicate laterality and their sequential disturbance during the ictus relate to the propagation of seizure activity. This information may be useful in conjunction with electroencephalography and functional MRI, when surgical removal of seizure foci in epileptic cats will become a practical treatment option. In the present study, we found that age at time of seizure onset was significantly associated with survival. Specifically, the risk of death in a cat with EUC increases 12% for each year after time of onset of seizures. This information should be of interest when discussing prognosis with cat owners. Furthermore, there was a significant association of survival with remission. That is, cats with remission survived longer than those without. Death was directly associated with seizures in 21% of cats, and as a consequence remission is likely to go along with prolonged survival. An important factor to consider is that older cats will have a decreased survival time simply because they are older. Hence it was important to include age of onset as a variable in the analysis to control for this factor. In survival analysis in human beings analyzing survival time for chronic diseases affecting mainly older patients, relative survival analysis is a standard practice using the life table of the population as controls to estimate any excess mortality or decreased survival caused by the disease in question. For example, the survival times of potentially fatal human alveolar echinococcus, where the mean age of diagnosis is 54 years, have been analyzed in Switzerland and compared with the normal population. Unfortunately, there are very little published data on the life tables of normal cats. However, the authors were able to find a life table published for Japanese cats, and the authors used this in a relative survival analysis to try and control for the natural increased death rates in older cats. This additional analysis did not change our main result that remission was associated with increased survival time. However, contemporaneous normal life expectancies of Swiss cats could be different. The overall rate of complete remission of 42% in this study was in accordance with the results of previous surveys. Thus, feline EUC is manageable and may have a favorable outcome. Our finding that the rate of complete remission was significantly higher in cats without AED therapy compared with those treated was unexpected, albeit there have been no large surveys evaluating outcome in response to treatment in cats with EUC. In a previous small case study, phenobarbital treatment was regarded to be required to maintain a seizure-free status because seizures recurred. In 6 of 8 of cats in which AED therapy was discontinued or the dosage reduced. However, our findings are in accordance with another recent small case series in which seizure remission was achieved in 3 of 5 cats without treatment. It is possible that there are different subtypes of EUC and or seizure phenotypes of different severity, neither requiring any nor continuous AED treatment. The fact that some of the cats categorized as being seizure-free without AED received treatment a variable duration before it was discontinued, while others never received AED renders this category heterogeneous and represents a limitation. Until methods are available to identify cats with less severe form of disease before discontinuation of treatment, AED should be recommended for all cats with frequent seizures in order to minimize the risks associated with uncontrolled seizure activity. Despite the wide availability of devices to document seizure events on video, detailed interviews with owners remain an important source of information for clinical signs of true seizure onset. In the present study, interviews were required to categorize the seizure type into primary generalized seizures and focal onset seizures with or without secondary generalization. While helpful, many homemade videotapes fail to document the entire epileptic event, which may lead to erroneous classification of the seizure type compared with videos. Owner-derived observations about seizure, however, appear less reliable because of recall bias, and therefore one might question their use for diagnostic purposes. In human epileptology, the dilemma is identical because epileptic patients may not be able to describe their symptoms, and information about semiology has to be obtained from individuals who have witnessed the seizures. In one semiology investigation of human patients with EUC, seizure types based on observer description were correctly classified in 85% of patients when compared with the findings from videotapes. The accuracy of the description was associated with the educational level of the observers. In a recent human study, there was excellent agreement between neurologists and caregivers for seizure identification when using a questionnaire-based description of video. Taped seizures description of seizure events is certainly a function of memory and time. However, individuals are remembering these highly emotional events better than non-emotional ones. Neuroimaging studies demonstrated that the amygdala plays a fundamental role during the encoding of emotional information. Individuals who show the greatest amygdala activity during the viewing of emotional items are those with the strongest emotional memory enhancement. Also, there is evidence that seizures in dogs induce physiological arousal due to psychological stress, and the same seems to apply for their owners with concomitant enhancement of their memory function. In the present study of cats with EUC, most owners were able to recall seizure semiology even after many years. Because seizures in animals are also emotional events for owners, we propose that reliability of pet owner-derived descriptions of seizures is similarly valid as in human beings. However, specific studies are necessary to confirm that this holds true for veterinary patients and their proximates. This survey was retrospective and relied heavily on owner recollection and observations. A limitation of the study was the assumption that each cat only suffered from one seizure type, and it is known that in other species such as dogs or human beings, more than one seizure type can occur concomitantly. From a clinical perspective, this classification was made on the basis of the presenting semiology, and thus we do not have the data to explore the hypothesis that survival may be linked to epileptic cats having more than one seizure type. Further, the lack of brain MRI of many cats in this study represents a limitation, as structural epilepsy could not be completely excluded. Indeed, lesions in the olfactory bulb or frontal lobe may not cause interictal neurological deficits. Focal seizures might have gone undetected in cats with complete remission. Also, the lifestyle of some cats includes the risk that some seizures are not witnessed. In conclusion, seizure semiology utilizing a structured questionnaire provides additional clinical information. Surprisingly, early onset of seizures in cats with EUC is associated with prolonged survival, and cats with EUC may become seizure-free even in the absence of AED. Semiology and seizure type, however, do not predict survival. Further prospective investigations are warranted to confirm these findings.
Looking through the study, one question I have is, what is the criteria for classification of epilepsy of unknown cause? There are not guidelines in cats like there are in dogs with different tier levels of confidence. That said, some of these cats could easily be argued to be cats with idiopathic epilepsy. Using the most recent reference cited for classification of epilepsy of unknown cause, this reference doesn't really discuss how to differentiate it from idiopathic epilepsy. I feel this is something that we as a veterinary community need to agree on in the future, especially for future studies, as there's likely a subcategory of cats with true idiopathic epilepsy. Thus, the purpose of the study was to examine survival and treatment of cats with epilepsy of unknown cause, but I feel we cannot answer that question based on that study design limitation. Additionally, the life table used for comparison from Japan was from 1989, which is fairly old at this stage, and I feel life expectancies have likely changed since then. I wonder if this study could have been designed in such a way that RDVMs could have also been contacted in addition to owners. 70 cats were excluded because the owners could not be reached, and I feel some of the patient information from the RDVMs could have led to inclusion of some additional cats, thus increasing the population size. Looking at Table 2, it seems that seizures that progress from focal to generalized might have a worse long-term survival. This also seems to be the case in Table 3, where cats had a worse remission rate, which if compared to Figure 2, these cats had a worse long-term prognosis. Again, remission being defined as 50% reduction in seizure frequency. My two biggest takeaways from this study are that the older a cat is at the age of onset of seizure, the worse the prognosis. Also, cats can go into remission without an anti-seizure drug. As they stated in their discussion, an anti-seizure drug is going to be recommended. That said, if an owner is not able to medicate their cat or the cat does not tolerate drugs, giving them time is completely reasonable as long as the cat is not suffering. I do wonder if cats that did not receive medications in the study didn't have as severe seizures, but this can only be speculated as they didn't go into detail on this, and maybe that's why they had a higher rate of remission. That said, with or without medications, I do agree that with this study, it seems that cats have a higher rate of remission compared to dogs. 71% of cats had overall a good outcome, and then 21% were euthanized due to seizures. I feel that this is similar to what I see in practice for cats that I diagnose with idiopathic epilepsy or epilepsy of unknown cause. Given the focal nature of a lot of the seizures, there is concern for hippocampal necrosis or sclerosis, which carries a worse prognosis, I feel, and I feel a lot of the literature supports that. Therefore, it's worth stating that a limitation of the study is that MRI or post-mortem was not performed on a lot of these cats. As I state, comparing this to reference 30, hypersalivation is associated with a worse outcome, and this is a common finding with hippocampal necrosis. Those are just my thoughts. I did enjoy this study and thought it was helpful. Thank you for listening.